Gracias. Buenos días. Es lo que sé hablar en español. So I'm going to speak in English because my Spanish is very, very, very bad. I'm going to be the voice of João Casanova. I came from Porto. I do essentially benign pathology and endometriosis. So I'm going to try to give you the experience of João Casanova as best as I can do. So João works in Hospital da Luz, which is a private hospital in Lisbon. He used to work in Champalimau in Lisbon also, so he used to do robotic before he went to Hospital da Luz. He does it for a long time than me. I only do robotics for 1 year. And he's now, I think, the head of the oncology division in Hospital da Luz. These are his disclosures. And this slide, I don't know what you wanted to do, but I think there are very good images and very nice images. So the agenda of this presentation is going to be an introduction. I'm going to talk about the challenge of building a robotic program in gynecology and in Portugal and in private hospital. I would like to speak in public, but I'm going to speak only in private hospital. In oncology, and I will try to do as best I can the data that João has until now. And some conclusions. So this is the Hospital da Luz. Is one of the largest private hospitals in Portugal. There are other largest because I work in another one. Well, so, but he's very big. He has 400 beds, 17 OR. He has the Da Vinci. She's now, the second one is coming. And yeah, it has also residencies in several specialties. And also it's going to be having residents in GYN in 2025. So I think it's the first private academic center in Portugal. So some data regarding the activity there's, in this hospital. It has a lot of deliveries. It's one of the largest maternities in Portugal. It has all areas in the field of OB/GYN and a lot of surgeries. So, what are the challenges of building a robotic program in oncology and in this setting? Of course, it's the patient. So the main problem, I think, it's the insurance coverage and the cost of the surgery, and of course some challenge in the hospital. So hospitals and private hospitals charge extra fees when they do robotic surgery, and in oncology I think it's a little bit higher, and it's very confusing to get the insurance to allow the expenses. And most of the times they deny. Then we have to work a lot and spend a lot of time writing reports and clinical reports and justifications. So in order to have the contribution of the insurance, because most of the times they consider robotics as an experimental practice. So this, I think, it's the main problem, it's the main challenge that we have in private hospitals. And also, it's even harder when we consider complex benign pathology. Even harder. It's very difficult, very, very difficult. So most of the times, it's either we don't do it by robotics or the patient has to pay extra payments. So the money, it's the main challenge. João started in May 2022 in Hospital da Luz. This is the setting. They have residents, and I think that the oncology unit has more than 200 surgeries a year. Regarding mainly the robotic cases, he has 74 robotic surgeries with a mean age of 55.7 and a mean BMI of 28. The ASA score, 70% was ASA 1 and ASA 2, and a little bit of also as ASA 3 patients. I think that I'm going to be able to, how can I put the video? I think there's a video. I don't know. Can you put it? Can you run? I think it's because João would like it to run, and it would like to here?
In the computer? I don't know.
Maybe here.
Maybe
okay.
Here. No. Here. Wait.
Yeah. Okay. So one of the data regarding the main surgery is the length of surgery was 165 minutes. The mean blood loss was 45 centimeters, I think, in English. And the median length of stay in the hospital was 1 day, with varying between 0 and 3. 4 patients stayed 2 or 3 days due to the length of the surgery, and 1 stayed because she wanted. Sometimes the patients don't feel very secure to go home after a large surgery, so they are afraid. I think it's understandable. So you can see there the precision of João doing surgery, and we have already see some of the surgeries by Oscar also. So this is a lymphadenectomy. I think I'm going to pass it because otherwise we'll be here longer. But I think he wants to show, as the previous speaker, the advantage of the robotic surgery in accessing and simulating the movements of the hand. So we are capable of more difficult approaches. In laparoscopy, we would be like in a circus, and there it's more or less anatomic and more or less ergonomic. It's more ergonomic. I think we're going to. So the next video, I'll start it before I go and stay. So João wanted to also give you the complications using the Clavian-Dindo grade 3 classification, and regarding that classification, he had 1.3 complications grade 3 or higher or greater. 1 patient with a bladder injury detected in the 5 day of postoperative, and he did the surgery and the repair, and afterwards had the vesicovaginal fistula, but now it's asymptomatic, and I think it resolved with probably with the bladder catheter. So he had no conversions, and once again, you can see the beautiful surgery that he's doing, and really, I can say that I'm a little bit older than João, and when we started our program, I thought at the beginning that I made a mistake because I was the older one and I was the head of the unit. I thought that I should be one of the surgeons that should be certificated by robotics. And when I started my certification program, doing the exercises, I felt very bad because I had awful punctuation, so I thought I'm too old for that. And now I really think it was a very good choice, because now I feel very good, because I even doing that, I was not very good in surgery. I think I can do now better, do well. So robotics is really a challenge, but it's something very nice to discover. So I will try to go. Also the ICG use in oncology, and so Regarding some data also, 45% of the final diagnosis of malignancy, 67% with malignance and or frozen section needed, and 5% risk reducing surgeries, the BRCA and Lynch syndromes. The malignancy was, 85% of the cases were endometrial cancer with sentinel node, and 7% with at least one unilateral mapping, and 90% with bilateral mapping. 30% of ovarian cancer, one secondary cyto reduction surgery, and 2% of cervical cancer and leiomyosarcomas. The procedures are these ones. Maybe I think 35 hysterectomies with bilateral salping oophorectomy and sentinel nodes, hysterectomies with bilateral salping oophorectomy and pelvic and lumbar-aortic lymphadenectomy and omentectomy, 5 of these, and 5 also hysterectomies, bilateral salpingectomy and oophorectomy and omentectomy, also 5 cases, and 1 secondary cytoreduction surgery for recurrent high grade of serous ovarian cancer. So I think it's a very good casuistic and numbers, and João wanted to conclude that building a robotic program in gynecology oncology in the private sector requires commitment, persistence, and from multiple stakeholders, the physicians, the directors, the financial directors also. They should be a team, and they should all have the same vision, or at least we could have the approximate vision. Remarkable benefits for patients without compromising oncologic outcomes. Patients with endometrial cancer are the bread and butter for robotic surgery. Early stage of ovarian cancer it's also some indications, and well-selected cases of recurrent ovarian cancers. Also well-selected cases of interval debulking surgery in ovarian cancer, but in these cases more data is needed, and also complex benign surgery, and this is, I completely agree. This is also benefit from robotic surgery. Endometriosis and pelvic floor, I think it's the main thing, but also difficult hysterectomies. Thank you very much, and I'm sorry.